Welcome to the RSSDI TV 2020. I am Dr. Sanjay Kamble, and on behalf of Wockhardt RSSDI T20, I welcome you all. I am glad to have with us today a renowned nephrologist from Varanasi, Dr. Kamlakar Tripathi. Sir believes in back to the society, and in his long way of vast experience in his clinical practice, now he's totally dedicated his practice only for the charity purposes. Hence, he is working with charity organizations. Welcome, Dr. Tripathi, sir, to the show. Based on your recent talk in RSSDI 2020, we would like to know, why are we lagging behind the targets to control the blood pressure?
We are lagging behind because of the lack of education, and we are not able to educate the masses, and we are also not able to educate the primary healthcare providers as well. Still, there are whims, and many people believe that once blood pressure is controlled, they don't require the medicine. Number two, there are different guidelines from different organizations, and people who belong to the older system still feel that you shouldn't lower blood pressure too much. So that's one reason. Second reason is the bad compliance of the patient. And now, because of the availability of the electronic machine, people are measuring his blood pressure. And the moment they think blood pressure is normal or okay and they don't have any complaint, they leave the treatment. Third is, though it is not very easy, but different target for different disease background. For example, for diabetes, target is little different, which people think it is same. For coronary heart disease, it is different. For chronic kidney disease, it is different. So these are the three different reasons why we are lagging behind and we are not able to achieve the target.
Thank you, sir. What are the barriers to achieve these targets to control the blood pressure?
Main barriers are the availability of the drug, which is though widely available, but then there are some time during the flood which we had recently in the Bihar and some of the area of the Assam, people are not able to store the drug. And the moment there is natural calamity, these are some of the medicines are not available with them. Number two, one barrier is the different guidelines. I said in the beginning also, these guidelines provide us different target, and the people who are the responsible people for writing the prescription and adhering to the treatment, then they try to give you different type of prescription. Third is the number of pills. Normally we all believe that as the age advances, the systolic blood pressure is the major issue, and when systolic blood pressure is the major issue, then the number of pills becomes different. They have a diastolic blood pressure. Some of them will be needing the diuretics. Some of them have a comorbid condition. So the number of pills increases. Either people tend to forget it or they pull medicine at one time and the pharmacological desired response is not there. Number four is the comorbid condition, especially the chronic kidney disease, which is usually as the age advances, number of functioning nephrons becomes less and less. And as the number of nephrons loses, the EGFR is reduced. And this is one of the reasons why we are not able to achieve the target. Fourth is the pregnancy-related hypertension. During pregnancy or pregnancy-induced hypertension, when the pregnancy is over, usually mothers leave the treatment and they don't comply with that. These are the 4 or 5 conditions which are responsible that we are not able to achieve the target. And these are the barriers.
Okay, sir. So what are the optimum medicines that could be prescribed to these patients to achieve the blood pressure goals?
Number one, we have to stratify. If the patient is young and he has got a lot of sympathetic overdrive, his heart rate is more, then we need to prescribe him still ACE inhibitors or ARB. So that is the one good target should be. And with the higher dose of ARB, we can give him a good lease of life. That's one thing. The second, if the patient has got a resting tachycardia, heart rate is more, then next comes the beta blocker. Calcium channel blocker are the good drug for the systolic hypertension. And as this systolic hypertension becomes difficult with the elderly patient, then we have to increase the dose of systolic calcium channel blocker. Then we have now newer molecule. And because of these newer molecule, we need to give them optimum dose. So the optimum dose would depend upon age of the patient, sympathetic overdrive, comorbid condition like coronary artery disease, diabetes, and chronic kidney disease. In chronic kidney disease, we require 4 to 5 medicines sometime because they have got fluid overload, they have got renal ischemia, they have got intraglomerular hypertension, and there's impending heart failure. So we need alpha blocker sometime addition. We need sometime addition of the calcium channel blocker, a little high dose, a good dose of the diuretic, and a beta blocker. So these are the 4 drugs which we require there. So optimum requirement would be at least these 4 drugs, 3 to 4 drugs for the chronic kidney disease, at least a combination of 2 drugs in the younger people, and in the elderly people, depending upon the resting tachycardia and the systolic blood pressure, they require 2 to 3 drugs. So a fixed dose combination would be better in initial time in the early age group. But then as the age advances, you need to break up these doses, and to prevent the resistant hypertension, a diuretic is also needed.
Thank you, sir. Thank you so much for sharing your views, and stay tuned to RSSDI TV 2020 for more recent updates from RSSDI 2020. Thank you, sir. Thanks for your time.
Thank you. Thank you very much.